Good evening, everyone. Thank you for joining us tonight for the Musculoskeletal Medical Update, part of the Inner West CPD series for general practitioners. My name is Lydia Koenig. I'm CPD Program Officer here at Central and Eastern Sydney PHN. And our GP facilitator for tonight is Dr. Leigh, local GP to the Inner West and advisor in GP Education Advisory Committee for the Inner West region. And I'd like to thank Dr. Leigh for his part in managing this event and bringing it to you tonight. Before we begin, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and pay respect to elders past, present and emerging. I'd also like to offer that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. Please note that this event is being recorded and will be available from our video library in the upcoming days. For the GPs in attendance, this event is RACGP accredited for the total of 8 CPD activity hours, including additional activities. Evaluation survey will be available at the end of the webinar and also will come to you in a follow-up email the day after. All the upcoming events are listed on our website, including 3 networking events for registrars, general practitioner registrars, practice managers and practice nurses as well. Please see our website to register and for more information. And I would like to ask for Dr. Leigh and his introduction of our speakers. Thank you.
Thank you, Lydia. Well, welcome everyone to our webinar tonight. Our presentation tonight is on sports medicine, and we're fortunate enough to have 3 excellent speakers. I will just give a brief introduction of all our speakers to start. The first speaker is Dr. David Samra. David is a specialist sport and exercise physician. He has a background in physiotherapy and later obtained first-class honors in medicine. He specializes in all areas of sport and exercise medicine and non-surgical orthopaedics. He has provided medical care to elite teams such as the Sydney Swans, Penrith Panthers, Cricket New South Wales, and national volleyball and rugby programs. Dr. Samra is actively involved in medical education, teaches at Sydney and New South Wales Medical School, and serves on several professional boards. He holds advanced training in emergency care, musculoskeletal ultrasound, concussion management, and international sports medicine courses, and has published research in sports injury, osteoarthritis, and platelet-rich plasma therapy. Our second speaker tonight is Dr. Leigh Golding. Dr. Golding is a specialist sport and exercise physician. He has extensive experience in treating elite athletes across various sports, including cricket, rugby union, rugby league, athletics, golf, and netball. Dr. Golding specializes in musculoskeletal injuries, ultrasound-guided injections, concussion medicine, and the mental health of athletes. We've published research in this area. He is currently the team doctor for the Australian men's cricket team and has extensive experience across elite sport, including International Rugby Union, the NRL, Super Rugby Australia, Australia A Cricket, Junior National Cricket Teams, New South Wales Swifts Netball, New South Wales Athletics, Sydney Ray, our NRC, and the President's Cup International Golf Teams. So Leigh is passionate about evidence-based care and stays at the forefront of sports medicine research. He has also shared his career journey on the Creative Careers in Medicine podcast. Our last speaker is Cameron Hyde. Cameron is an accredited exercise physiologist. He with expertise in metabolic health, body composition, and musculoskeletal rehabilitation. Through his work at Progressive Sports Medicine, he has helped patients and clinicians navigate the intersection of exercise therapy, muscle preservation, and modern treatments such as GLP-1 medications. His approach integrates evidence-based rehabilitation with longevity principles, focusing on protecting lean mass, improving cardiometabolic health, and building sustainable long-term outcomes. So our first presentation is by Dr. David Samra, and he will be talking about knee and foot injuries in sports medicine. Thank you, David.
Thank you very much for the introduction, Edmund, and Lydia, thank you for organising. I appreciate the opportunity to share our knowledge. Obviously, very excited to be able to present with two excellent co-presenters, Cameron Hyde and Leigh Golding. And we just want to really give you a, we know it's the end of a long day for everyone, and want to give you a good high-level overview of the common sports medicine presentations around the knee, foot, shoulder, and hand, and some of the best frontline primary management things to assess and things not to miss, and how to think about referral. So this is just a brief view of our website. It's been a great opportunity to develop some useful educational content for patients. We've got many hours of educational videos, good synopsis and summaries. And I think it's a good resource if you are pushed for time in terms of explaining the common issues for patients. Some good resources on our website, and certainly not every patient needs to have a sports medicine consultation, but if this is helping people get some perspective on their injury or their condition, then it's definitely worth the time invested. So just briefly, I think an overview of the principles of management, because if you're uncertain as to the management of every individual injury, which is onerous to think of all the things that can occur in our field, considering all of the many things as a general practitioner that you also need to be all over, it can be a bit overwhelming. So I think it's good to go back to some first principles. And those first principles in the first phase, when someone is injured, we've changed it. Over time, it's evolved from RICE, what used to be rest, ice, compress, elevate, to police, which really the main emphasis change here on acute injuries is to protect rather than necessarily rest. So depending on the injured part, how you're going to protect it in the acute phase. Optimal loading instead of pure rest, because you can cause harm if you immobilize an injury in the wrong position or for too long through atrophy and joint stiffness. And really the goal here is to protect the injured region, whether it's bracing, strapping, or even just giving a patient some time off work. And I think that emphasis change is a helpful way to think about things. And then some ways of reducing the acute inflammation and arranging appropriate review, which is hopefully going to come across today. We're also going to send out a summary table for the things to keep an eye on, the things not to miss, and some of the ways of thinking about orthopaedic versus sports medicine referral. And just briefly, after this initial phase, we move to phase 2, which is the rehab or mechanotherapy phase, and then, of course, the return to sport or coaching phase is the final phase. And we do like to be involved as people find their way back from injury there as well. So firstly, meniscal tears. Well, meniscal tears are a very common cause of morbidity in our society. They're usually non-acute. So they usually, it's actually unusual to see an acute meniscal tear. And the vast majority of these live on the spectrum of degeneration. You can see the knee is made up of 3 compartments here that you can see anatomically. This little view is looking inside the knee at the ACL, the medial and lateral meniscus. And those compartments are designed to spread out load and maintain smooth, frictionless motion. And the menisci are made up of densely packed type 1 collagen fibers forming fibrocartilage. And the fibrocartilage is a lot like, it's in texture, it's a lot like calamari. It's smooth and glossy, but it's certainly got more thickness to resist compressive impact forces. And it can also resist stretching and tensile forces. So it's quite a specialized tissue, the meniscus. And its architecture is also very specialized. That collagen is arranged so that it can resist rotational forces and it can absorb vertical forces very well. In effect, the meniscus allows a rounded bone, which is your distal femur, to fit very well on a flat bone, which is the tibial plateau. So it creates congruence and stability. And of course, it protects the underlying cartilage that lines those bones. So we know that the meniscus is a critical structure, and even partial meniscectomies drastically increase the risk of knee osteoarthritis by about 5-fold. So wherever possible, we want to preserve meniscal tissue. And its blood supply is really key in understanding meniscal injuries, because the outer third is where all of the vascularity comes from, the periphery of the meniscus. And therefore, the inner thin lining, the free margin of the meniscus, along the inner part of the joint, has the poorest blood supply. So tears that occur in that range have very limited healing capacity, and they're also they won't heal with suture repair in a younger patient, for example. So we do see acute meniscal tears in younger patients, and they tend to occur with rapid rotational compressive mechanisms. So tennis players, we will remember, Roger Federer having a meniscal tear, baseballers. But again, they're unusual in isolation, and many of these injuries, they occur with other high energy and ligamentous injuries like ACL tears. And of course, we much more commonly are going to see chronic meniscal tears. And I think they should be viewed more as wear than as tear. And we've definitely changed in our approach to management, where 20 years ago, many patients who had degenerative tears were getting arthroscopy. So patients will generally have pain with these acute tears that localizes to the side of their meniscal tear. They'll have swelling of the joint and obviously pain with loading and twisting movements. And all of the meniscal tests are designed to recreate that rotational mechanism. So mechanical symptoms are what we need to look out for. And we're looking for true locking as opposed to pseudo-locking. So pseudo-locking might be a patient's description of being unable to straighten and bend their knee, or a slight catching in the joint. True locking is the actual inability to push past a fixed blockage of movement, and that's certainly more concerning. And then giving way of the knee is a little bit more of a subjective criteria for mechanical symptoms, but it is also considered a mechanical symptom. So in those cases of mechanical symptoms in younger patients, obviously the range of criteria for MRI has reduced, but referral for MRI and surgical opinion is very fair in a younger patient. So there's a variety of different patterns of meniscal tears. Peripheral tears tend to occur toward the areas where there's more blood supply, and they can often be quite painful, very much vary in their stability. And in these tears, these peripheral tears, surgical opinion should be obtained. Tears can then progress and they can become unstable bucket handle tears. And this is where a section of the meniscus flips all the way into the intercondylar notch, flips right in there, just as you're seeing on the animation. We've got radial tears. Sorry, this is the flap tear coming into the joint. This is a radial tear, which is a tear of the free inner margin of the meniscus, and that can turn into what's called a parrot beak tear. That's just an extension of a radial tear. And then complex tears are just combinations of these different tear orientations. usually affecting the inner avascular margins of the meniscus, so they're not repairable. So basically, if a patient complains of sudden onset joint line pain, medial or lateral, and they're a younger age, particularly playing a high energy sport, then they should raise your concern for a peripheral or radial meniscal tear. If they complain of sudden onset posterior knee pain, but usually with a twisting mechanism, then we need to consider a posterior meniscal root tear. So if we're looking at the meniscus at the back part, it's anchored down, both menisci are anchored down into the tibia by what's called the meniscal root. And if you tear the root, then the meniscus does not have any stability to hold it onto the tibia. And when you push down with the femur, it slips out, so it extrudes. So these are particularly important to pick up, these root tears, because the pain can resolve within a couple of days, and you may miss the boat. You may miss the opportunity to repair the meniscal root, which often needs to be done within a few months. If you do have an extruded meniscus because you've torn your root, you'll rapidly develop osteoarthritis because the meniscus won't be functioning to protect the cartilage. And these are the most common tears you've all seen. I'm sure dozens of patients with these horizontal degenerative tears where the meniscus just loses its integrity, but it doesn't tear from top to bottom. It tears horizontally through the plane. And of course, they're not repairable, but they're on the spectrum of tissue where generally strengthening gets people back on track with these tears. I'll just move on. So first-line treatment for stable meniscal tears that aren't displaced or causing locking or mechanical symptoms is a non-surgical approach, and that's relative rest, strengthening and optimal loading, and sometimes anti-inflammatory treatments such as a corticosteroid injection or a course of NSAIDs. And if the pain and swelling are impeding their ability to perform even strength exercises, that's when medication or injectable adjuncts are often very effective to settle their pain and provide a window of opportunity for strengthening. Obviously, we try to use corticosteroids sparingly, as multiple injections in short succession have been shown to accelerate chondral wear. Biomechanical assessment often is important to have an awareness of aggravating movements and malalignment of the knee, as a patient with a medial or lateral meniscal tear may have a relevant malalignment that overloads that meniscus. Overall, after a minimum of 8 weeks of strengthening, I think I've done something there, an 8-week strengthening approach, if a patient is not making any progress with meniscal pain, I think a surgical opinion is warranted. We certainly want to avoid surgery, and the research does show multiple consistent studies saying there is no overall difference between partial meniscectomy and sham surgery, or even no surgery, for patients with stable meniscal tears in their longer-term outcomes. So it's we've got to be slow to make the decision for referral to orthopaedics in that regard. ACL injury. I haven't included slides on medial and lateral ligament injuries of the knee, largely because these heal quite well, and usually a clear mechanism is described with a varus or valgus injury to the knee. The ACL is really the major one that we'll come across, and it's a big cause of morbidity in active adults because the ACL is so crucial to rotational stability. So once a patient tears their ACL, the ability to play any cutting, turning, sports, running sports often, and even their activities of daily living can be very difficult, as generally they don't trust their knee without a functioning ACL. And in the past, I think the gold standard management for ACL disruption in active young patients has been reconstructive surgery. And this is in order to restore the rotational stability. So because of the risk of injury to the menisci and other structures in the knee, chondral wear in the knee, most surgeons would argue that almost any patient with an acute ACL injury should consider repair. But increasingly, we're seeing functionally and structurally adequate results from non-surgical management. A colleague of mine, Dr. Tom Cross, has now followed over 1,000 patients who were all very carefully selected with early isolated mid-portion ACL injuries, so within 2 weeks where the middle of the ACL has been disrupted and had not been displaced or retracted on their MRI. And he's used a bracing protocol, which is very conservative over a 2 to 3 month period. And so far, the imaging results are very positive, with over 80% of the ACLs showing structural healing. We are yet to see how the long-term results functionally compare to surgery, and that's something we're very much keeping our finger on the pulse of. But it's certainly an option to consider in children and people outside the range where they might be considering surgery. The diagnosis of an ACL injury should be based primarily on the index of suspicion from the injury mechanism, particularly if they describe very rapid early swelling and a hemarthrosis is visible when you examine them. And it's obviously better to demonstrate these tests in person, as they can be subtle to perform and interpret. And if you're not doing it regularly, you may not have the sense of feedback and feel that's required to feel whether the ligament is intact. The top one is called Lachman's test, and you can see you're pulling the tibia forward with the knee flexed at a relaxed 20 to 30 degree angle. And you're feeling for an end feel, but also how much movement there is before that end feel. And the test below that is the pivot shift test. And this test is testing the rotational function of the ACL. It's a little bit more difficult to describe, and even I think myself and my colleagues would more rarely perform it, because it is quite, in order to perform the test, you actually need to sublux the tibia. So it's uncomfortable for most patients with an acute ACL injury, and they won't let you do it. They'll usually guard in the acute phase. But the Lachman's test is the test we will all be performing on the field or in the clinic in the acute setting. This is an MRI demonstrating progressive healing of an ACL injury. This is a mid-portion ACL injury. You can see in the sagging of the ACL. The two ends are just discrete. I think it might sound biased, but patients with an isolated ACL injury should ideally be referred for an urgent MRI and straight on for sports medicine review. It then gives them all options on the table, and this may include non-surgical options if they're suitable, and of course surgical options if that's the most appropriate course of action. Because if there's concomitant meniscal injury or chondral wear, they really should go straight to an orthopaedist for an opinion. Patellofemoral dislocation, it can actually mimic an ACL injury or look very similar in its presentation. So it's very important to consider it as a differential. In patients who've had an instability episode for the first time, and they often can't describe to you exactly what happened, but they'll usually say they were twisting, landing awkwardly, and most of the time it will happen without any contact. So you can see here, this is a patella that's quite lateralized in the trochlear groove. It's sitting out perched toward the edge of the socket. And in this particular person, they've got anatomical predisposing factors like a shallow groove and an atrophied ligaments around their knee. So this is what we would term atraumatic instability, where the patella's pretty perched and ready to track outwards. And will usually happen in those hypermobile patients with laxity of all of their ligaments. So it takes really minimal trauma for it to come out. This is an animation of traumatic instability, and it shows acute disruption of the stabilizers of the patella. You can see, obviously, you can be struck directly. That's the medial patellofemoral ligament that's been torn. And in this particular animation, it shows a little fragment of cartilage that's come off in the trochlea. So these patients will know that something came out, or sometimes the patella will remain dislocated in those patients, and they have a very rapid onset of swelling. This is how you shouldn't reduce a patella. This is a former Swans player, and obviously you can have, it's quite a traumatic mechanism of reduction there. And this is an example of a less traumatic reduction. We'd normally really try to relax the patient a bit more than this. You can see he's sitting right up. I'd have his thighs supported, so that medial glide on his patella, and then just extending the knee is key to getting the patella to track back into place. Now on the right there, you can see this is called the moving apprehension test, and where are we? In this test of the patella stability, you're holding the patella and hanging the leg over the edge of the bed, and this gives you a really good indication as to whether the person has dislocated their kneecap, and without actually dislocating it. So you can see the hand is holding laterally, and as you flex and extend the knee, if you track the kneecap slightly to the lateral side, the quadricep will usually contract reflexively, or the patient will feel very uncomfortable. And that's a very sensitive test for patellar instability. Sometimes it will be hard to tell, but if I'm assessing someone with an acute knee injury, I'll usually be doing this test and a Lockman's test to see whether I have an ACL injury or patellar dislocation. All patellar dislocations or suspected patellofemoral dislocations require an MRI to assess for chondral damage. And the reason is that a significant osteochondral injury or a loose body that's created by the trauma of the dislocation can warrant surgery. Obviously, if you've got a loose body of cartilage floating around in your joint, you're potentially going to damage the rest of your cartilage, particularly behind the kneecap. Acute management, we used to use a Zimmer splint for these patients. That's a straight leg splint. It's much preferred to use a ROM brace now for the first 2 weeks. The ROM brace has the advantage that you can take them out of 0 degrees gradually. They're usually going to take about 6 to 8 weeks to recover their strength and their range of motion. But in the first 2 weeks, it's advised to keep them at 0 degrees, keep them fully extended, so that the medial patellofemoral ligaments are under the least tension and can heal back into its place. And then regular reviews every 2 weeks to extend the ROM brace generally gets people going the right direction. If a second dislocation occurs, then an orthopaedic opinion is warranted, but an isolated first-time dislocation without any structural damage or osteochondral lesion can certainly be managed conservatively. So I might just move on from ankle sprains because I think we will focus a little bit more on the foot. So importantly, they go together. An inversion injury of the ankle can certainly lead to issues in the foot, and that mechanism is very common. If we look at the Ottawa ankle rules, obviously the idea is to minimize cost and radiation, and not every patient who sprains their ankle needs an X-ray. So we're trying to funnel in those patients who should have an X-ray. It's important to palpate the back of the medial and lateral malleolus, but also the navicular and the base of the fifth metatarsal. Those bones are really important to examine because of their very poor blood supply. And so we want to pick patients up that have had an injury in those as well. If we, obviously look at the foot, we talk about the 5 occult fractures that can occur, and this is just a little anatomical reminder. Obviously, you can injure the ATFL, the ligaments of the foot and ankle, but the avulsion fractures are actually quite common. That's at the base of the fifth metatarsal. You can injure the talodome just next door to that laterally. Anterior process of the calcaneus is a very common site of an occult fracture, and you won't see these, commonly you won't see them on x-rays, important to realize. So around the foot and certainly around the hand, the anatomy is really good at guiding us to where the pathology is. So I think examining a patient, and if you don't see anything and they've just had an ankle sprain and they can walk a few steps and they don't have significant bony tenderness, I think the common sense, rational thing to do is to offer them a review at 2 weeks and just to ensure that they're recovering. I think patients understand that our tests aren't perfect and we can't go around doing an MRI and a CT scan on every person that has an ankle sprain. So Assessing and reassessing an ankle sprain after 2 weeks is I think a good way to approach it, with the knowledge that we do miss things around the foot and ankle, even with plain imaging, with X-ray. So just referring to the navicular is a really critical bone in the center of the foot. They're really important to pick up fractures of the navicular, and they normally happen as stress fractures rather than acute fractures because it's got a very poor blood supply. So it's sort of at the keystone of the foot. It's right in the middle of the foot there. It takes a lot of pressure. You can see on the diagram on the left there, there's this sort of nutcracker effect that occurs between the talus and the cuneiform bones that pushes into the middle of the navicular. And patients who are runners, very physically active, particularly athletes, can often get overload injuries in the navicular. So it's, I think, really important to try to pick them up early. If you do notice tenderness right in the middle of the foot next to the tibialis anterior, when you're feeling around the foot, around the top of the navicular, the index of suspicion is enough to immediately non-weight bear that patient until you do get further imaging or a specialist review. These fractures have a very high rate of non-union, and patients who have them are usually the most active people who are the most devastated when you tell them that they need to suddenly non-weight bear. So there's a little bit of a psychological component to managing these as well. The results of complete non-weight bearing in a boot or a plaster are far superior than if you put them in a boot and allow them to walk around or weight bear at all. So, in patients who are really non-compliant or you think they're going to walk on it, we sometimes even will go forward with a full plaster. So, of course, if in doubt, if you think someone might have a navicular stress fracture with pain over what we call the end spot, right in the middle of the top of the foot, it's reasonable to ask them to non-weight bear with crutches until they have an MRI or see a specialist. And sometimes we'll even do it, just start with a CT scan with fine slices to look for any cortical breach of the bone. So unfortunately, a very frustrating season-ending injury, at least sort of 12 weeks to recover from this injury, but at least 6 to 8 weeks of non-weight bearing. Base of the fifth metatarsal is very similar. It's got a poor blood supply in an area that we term the Jones fracture. It's at this watershed area of blood flow because the blood flow is predominantly distal to proximal. So this is a stress injury as well. The majority of the time, patients may get one instance of pain, of sudden pain, but they've usually had it brewing for a while. And again, unfortunately, although you can usually pick them up on X-ray with a plantodorsal oblique view, they'll usually need to non-weight bear for at least 4 weeks with regular review. So again, usually an innocuous mechanism. And the important thing is to differentiate them from avulsion fractures, where someone sprained their ankle and just tugged off the edge of the bone. You can see on the there's an example of an left there. It's a little bit lower down than the avulsion fracture, where we expect the Jones fracture. And the management is quite different. So obviously you can weight bear if you've got an avulsion fracture in a boot, but if it is a Jones fracture, we should be non-weight bearing these patients for at least 6 weeks, usually 6 weeks. So again, if they're high demand patients, sometimes we do consider orthopaedic referral because the recovery rate is time is similar, and there's a non-union rate of about 30%, up to 30% with these fractures. So another injury that's notoriously easy to miss is a Lisfranc injury. And I've certainly been at football games where I've seen players at halftime who complained of a little bit of foot pain, who have turned out to have partial Lisfranc ligament injuries. It's really critical. In order to provide stability to the midfoot, you can see this bone through the middle on the animation, the second metatarsal. It's longer than the rest. It's really kind of locked in and surrounded by these other bones, a lot like a key and a lock. And when the foot turns into eversion and pronation forcefully, it can pull apart the mechanism between the medial cuneiform bone on the medial side and the second metatarsal. And that's where the Lisfranc ligament lives. And obviously, a patient will feel a lot of pain. They sometimes, when you examine them, will have a huge amount of bruising under the foot. That's a definite flag for you to consider referring. If you can see bruising under a person's foot after they have a twisting injury to their foot, that's plantar ecchymosis. And they're very tender if you pronate and invert their foot, or if you move the second metatarsal up and down. So if you've got the suspicion of a Lisfranc injury, I think the best imaging available for that, because it can be partial, can be nuanced, is a weight-bearing CT. And I think there's one good scanner in Sydney that does a weight-bearing CT called Macquarie Medical Imaging. And that can actually determine whether, when they're weight-bearing, the interval between the second metatarsal and the cuneiform is widening. You can X-ray both feet and look for widening, but I find that's often equivocal and difficult to tell. So generally, I would refer starting with a weight-bearing CT if you suspect this midfoot injury. And if they've got an unstable injury, it's straight to orthopaedics. And whereas if it looks stable, then certainly a sports medicine review is indicated then. Lastly, Achilles tendon rupture. The ruptures of the Achilles are not that common, but a delay in the diagnosis or treatment can drastically affect the outcome, because the edges of the tendon can separate further away and distract, and therefore the tendon, if it does heal, will heal in a lengthened position, so the calf muscle will always be weaker and always operate from a shortened, weaker position. Main risk factors are diabetes, certain medications, certainly anabolic steroids, and fluoroquinolone antibiotics. So if patients are on fluoroquinolones like Cipro, I'll usually ask them to stop plyometric activities for about 6 weeks to reduce the risk. And most patients with an Achilles rupture, paradoxically, have little or no pain in their Achilles before it ruptures. They'll usually look around for someone that they think has hit them in the back of the heel at the time of rupture, and it becomes painful, obviously, and weak to weight bear, but they often can still walk because of intact long toe flexors. And importantly, the diagnosis is clinical. It shouldn't require any scans. And this is the classic test for an Achilles rupture. On the left, you can see the angle of the ankle is hanging very, very vertical. That suggests that the tension in the Achilles has been lost. And then when you squeeze the calf, this is Thompson's test, the ankle's supposed to move up. And if it doesn't, then the Achilles is not intact. So imaging can, in fact, confuse the picture and delay treatment. This is an example of an ultrasound that was reported as a partial tear of the Achilles, when, in fact, hematoma had filled the space and made it appear that it was a partial tear due to the echogenicity of the hematoma. So we now know that Achilles ruptures can be very effectively treated without surgery in compliant patients. In the NHS, virtually everyone goes through non-operative treatment. And really the key is early recognition, because in this position, you can see the two ends of the Achilles tendon are approximated, and a patient therefore has a chance to heal their tendon in the best position. So anyone that you suspect has had an Achilles rupture should be given crutches for the first couple of weeks, and ideally put into a boot or plaster with the toe pointing down. This is the Aquinas position. And really, they can be stepped down after a couple of weeks into a boot with lots of heel raises in that boot, so their toe is still pointing down, and gradually brought back to some weight bearing as tolerated. The problem with the normal immobilizer boot is you can see the Achilles, if you're immobilizing them at 90 degrees, the Achilles ends are going to pull apart, and that's going to lead to poor healing, as I mentioned. So surgery for Achilles tendon injuries is not always the right thing. The studies show that calf strength and return to sport confidence and re-rupture rates are all slightly improved with surgery. But again, the most important thing you can do early is to have that ankle put into the pointed position so the torn ends of the Achilles aren't being pulled apart or retracted. Okay, so that's it from me. I'll move this on to Dr. Golding.
Thank you, David, for such a engaging, informative presentation. Especially like all those 3D images. So yes, our next speaker is Dr. Leigh Golding, and he's going to talk about the foot, the shoulder, and the hand injuries. Thank you.
So thanks, Dave. Good evening, everyone. Thanks for having me. I'm Leigh Golding. I'm a sports medicine physician as well, and I'm also the team doctor for the Australian men's cricket team. Today, mainly, I'm going to be focusing on conditions that can trip us up at times in the hand and the shoulder. I've tried not to keep my slides too busy. Unfortunately, I don't have the same great 3D videos that Dave has, but I've tried to include at least one take-home point on each slide. And I believe there's an opportunity for questions at the end of this talk. And certainly if anything comes up, please feel free to put it in the chat and we can get to it at the end. So here's what we're going to be talking about for the next 30 minutes or so. We'll start with 3 hand injuries that are easiest for us to get wrong at times in the acute setting. So that's scaphoid fractures, the mallet finger, and skier's thumb. So these conditions are really common and we'll all see them regularly. After that, we'll move on to the shoulder and we'll talk about frozen shoulder versus OA, which we all know comes up quite regularly and can be tricky to work through. And after that, I thought it'd be useful to talk you through my process when it comes to decision making when we're faced with rotator cuff tears. Obviously, we all see those a lot and they can be tricky to navigate as well. Okay, scaphoid fractures. So this is one of those injuries where what you do on day one really matters for the outcome. Obviously, the classic story here is a fall onto the outstretched hand. So whenever we have that mechanism, we should always be thinking about a scaphoid fracture. And the examinations that are important here are having a feel over the anatomical snuff box. So you can see the picture on the bottom there with when that thumb is abducted. You can see the anatomical snuff box. So palpating over that and feeling for tenderness. And I also find that axial compression of the thumb is useful. And certainly if the patient has had that mechanism and they're localizing pain there, then we should be highly suspicious for a scaphoid injury. Particularly tricky thing about these scaphoid fractures is often the initial x-rays are normal despite there being a fracture there. And so they're not well visualized. So if there's a degree of suspicion, we should just immobilize them and treat them as if there are a fracture in a rigid thumb spiker. If there is a great urgency to actually define whether there's a fracture there or not, so if you know someone's not going to tolerate a splint for 2 weeks while we wait for a repeat x-ray, or if they're an elite athlete, for example, then MRIs are very sensitive for this in the acute setting. Otherwise, for most people, it's very reasonable to immobilize them for 2 weeks and then repeat an x-ray at around that time. And by that time, the sensitivity of the x-ray will have improved a lot. If they're non-tender then at the 2-week mark and they have a normal x-ray, then that's highly reassuring. And we might be able to mobilize them at that point if they're asymptomatic and the x-ray is normal. The reason we don't want to miss these fractures in particular, not that we want to miss any, but these ones in particular, is that loading these can lead to avascular necrosis just of the proximal pole of the scaphoid. And if that happens, there'd be significant functional consequences for the wrist down the track. So it's really important to keep an eye out for these fractures in particular. So mallet finger, all of these injuries are in the public domain, so I'm sure Steve won't mind me talking about this. It's an injury that we see regularly in sports medicine. I imagine everyone sees it regularly in general practice too. So the mechanism here is a forced flexion injury with an extended DIP joint. So in cricket, for example, we see these when players attempt to catch and get struck on the end of the finger by a ball. So in the last 2 seasons, we've had Mitchell Starc, Glenn Maxwell, and Steve Smith have all had this. Steve was the most recent. So in the World Test Championship final in Lords, we've got a picture up the top there. he attempted a catch, and he actually ended up having an open mallet finger. So that's when the end of the middle phalanx was sort of visually protruding through the volar surface of the skin there. And we had to walk him through the long room at Lord's in front of all the spectators with the bone poking out the finger. So that was a particularly gruesome version of this recently. But we will all see the normal closed versions quite regularly. And the reason I put this injury in here in particular is because often the initial presentation could be quite subtle. So there may only be a very minor extensor lag, and if we don't check for it, we might not find it. So specifically what we want to do if there has been an injury to the end of the finger, you know, an attempted catch or something similar, is we want to look from the lateral aspect and check for an extensor lag of that distal phalanx. And so if we see that there's flexion there and the patient is unable to actively extend that DIP, then that's, you know, that should be considered a mallet finger, and we should put them in this mallet splint straight away. The other thing that we should do there is get an X-ray just to check for an avulsion fracture, or just to make sure that DIP is not volarly subluxed. If they have a significant avulsion fracture that involves more than a third of the joint surface, then those are the ones that you consider repairing. And if they do have that volar subluxation, again, they might be surgical cases. But if the X-ray is reassuring, then the treatment for this is splinting for 6 weeks in a mallet splint like that, with the finger in full extension. Often we'll see young, sporty people having this injury, and it's really important when we're applying the splint to counsel them about the consequences of removing the splint. So if they take it off to clean it or to wash it, they must be counseled that if they flex that DIP, then their healing, you know, their timeframes essentially have to start from zero again, as they're disrupting that delicate healing tissue. The other reason I put this this injury in this presentation in particular is because often we'll see, when we're looking after football teams, players presenting at the end of the season, they haven't always declared or felt the need to declare this injury in the first instance, and then over time they've gradually gone on to develop a quite severe swan neck deformity. And so if we don't identify this in the early phase, then later they can get quite bad swan neck deformities over the course of a couple of months, and they can be really difficult to correct down the track, which is why it's imperative to find these early and manage them properly, because the management is quite simple. So skier's thumb, despite the name, I much more often see this in athletes that play the football codes, where the thumb gets forcefully abducted in a tackle, for example. So this injury is a tear of the ulnar collateral ligament of the thumb MCP joint, and the clinical test we do for this is the valgus stress test at the MCP. And it's worth doing that valgus stress with the thumb in extension and stressing it with the thumb at 30 degrees of flexion. Just a clinical tip here is just make sure that thumb is in the neutral position when you then go to apply the valgus stress. Sometimes when there is significant laxity, it can start in that valgus position, and then you're not going to notice much of the difference when you do apply the valgus stress if it starts there. So make sure it's in neutral to start with, and then apply the valgus stress. And then compared to the contralateral side, some people are a bit more ligamentously lax than others, so you'll get a good feel for whether there's a side-to-side difference when you compare with the contralateral side. This is a sort of a clinical diagnosis. Usually there's tenderness on that ulnar aspect of the MCP, and there might be a side-to-side difference in terms of the valgus gapping you get there. But probably the one thing I wanted everyone to take away from this is that there's one more thing we need to check for with these injuries, which is something called a Stener lesion. So that's when the torn UCL retracts and flips over the adductor aponeurosis. Once the aponeurosis is interposed between the torn ligament ends, it physically can't heal because those ligament ends aren't opposed anymore. Those ones need surgery. So we can't splint our way out of those, and that's why we need to identify them. So clinically, once we've identified the injury, we put them in a thumb spiker splint, just like on the image. Then we'll arrange an X-ray first to look for a bony avulsion. If there is a bony avulsion, then in some respects that can be reassuring because we know there's a bony anchor for the ligament to heal onto. If the X-ray is normal but there's obvious clinical gapping there, then it's very reasonable to arrange a ultrasound or an MRI at that stage just to check for the steno lesion. And if those are reassuring, then the treatment is that thumb spiker for 6 weeks or so. Carpal tunnel syndrome, I know everyone sees a lot of this. Most common peripheral nerve entrapment. Hallmark symptom that really nails the diagnosis is night pain. Patients wake up with numbness and tingling in that medium nerve distribution. The bedside tests, Phelan's test for 60 seconds just to reproduce that symptom, Tyndall's test over the carpal tunnel. The initial management is nocturnal wrist splinting, and for those that fail that, cortisone injection can be therapeutic and diagnostic. Those that are still struggling after that, most of the surgeons want nerve conduction studies in order to be performed if they're going to consider surgery. I won't talk too long on this, as I'm sure you see a lot of this yourselves. A couple of slides here on just high value injectable interventions around the hand and wrist. So de Quervain's tenosynovitis. As you know, this is incredibly common. New parents, office workers, gamers, or anyone who's had a recent upgrade in repetitive thumb and wrist movements might get this. And it's a clinical diagnosis. So if there's tenderness over that radial styloid and pain-resisted thumb extension and a positive Finkelstein's test, then we know we're dealing with de Quervain's. So just tips for that Finkelstein's test. Make sure just to immobilize the wrist itself. Then we are asking the patients to wrap their finger around the thumb, and then we're doing ulnar deviation of the wrist with an immobilized wrist. That's the way Finkelstein's test is described, and that's very sensitive for de Quervain's. Lots of those respond really nicely to corticosteroid injection. And for those that don't respond to an initial blind corticosteroid injection, it's often worth then doing under ultrasound. Many patients have a separate compartment for the extensor pollicis brevis within the first dorsal compartment. And it matters because if you inject into only one of the subcompartments, you miss the other one entirely and that injection will fail. So that's most of the reason why people don't get a response if they have clinical de Quervain's and they don't respond to the initial injection. So then it's good to refer and actually make sure they're getting an injection on each side of that septum so they can respond to it. The other high-value injection around the hand is a trigger finger injection, which is stenosing tenosynovitis of the flexor tendon. It presents as like a palpable lump or nodule at the base of the finger. The finger catches or locks and snaps during flexion and extension. Much more common in diabetics, people who are middle-aged, and women, and people doing repetitive gripping activities. I've seen it a lot in rock climbers, actually, in the sports medicine context. And interestingly, the first line of treatment for these is an ultrasound-guided corticosteroid, which is usually not the case. Usually we're advocating rehab and strengthening and offloading things before we actually go to the injectable therapies. But these do really well with injections early on. And the evidence is quite strong for that. And a single injection resolves symptoms in about 60 or 70% of cases. And a second injection bumps that up to around 80% of cases. The injections do tend to work less well in diabetic patients, so I do tend to counsel diabetic patients regarding expectations in that regard. But for all these patients, getting an injection first is really valuable, and most of them can expect excellent outcomes. CMC joint osteoarthritis, base of thumb arthritis, one of the most common causes of hand pain in patients over 50, and it's particularly prevalent in women. People present with pain at the base of the thumb, worse with gripping and pinching and opening jars, turning doorknobs, things like that. On examination, we're looking for tenderness on palpation as well as pain on the grind test, which is basically where you axially compress through that first metacarpal and rotate back and forth that CMC joint. And if that reproduces their pain, then we've got a clinical diagnosis of CMC osteoarthritis, and x-rays will confirm it for us. Hand therapy and splinting are genuinely effective for early to moderate CMC osteoarthritis. So if it's their first presentation and they've otherwise been managing well up until this point, then they usually do very well with splinting for offloading and hand therapy. Injections can be useful later on if they're failing those strategies. And when we do inject, I think these are good ones to get under ultrasound guidance as well, because you would think that this joint is reasonably accessible with the blind injection, but there has been some studies that show that that many of them miss when done blindly. So I certainly think that a steroid injection is useful here if they're failing conservative measures. For advanced disease that's failing all those measures and not responding to injections, then the operation is a trapeziectomy, but thankfully most people don't progress to a stage where they need that. So moving on to the shoulder then, the stiff shoulder, it can be quite difficult to differentiate between emerging adhesive capsulitis and glenohumeral osteoarthritis, which is why I've chosen to include this. But it's quite important to try and establish the diagnosis here early, as the management is quite different for each. Typically, the osteoarthritis patient may have had some shoulder symptoms on and off for some time that have become worse recently. And the frozen shoulder patient may have been asymptomatic for some time prior, but unfortunately, the history isn't always that simple. I think the quick clinical tip here is to check passive external rotation in particular. So if you get the elbow tucked in, like in the picture there, tucked in against the lateral chest wall, and then passively externally rotate the arm. And we're checking for restriction in external rotation, and particularly a side-to-side difference. If there's cracking or crepitus or a hard mechanical block, that might favor osteoarthritis. But if there isn't, and there is a side-to-side difference in that external rotation, and it's new, then it's favoring adhesive capsulitis. A simple X-ray series of the shoulder should establish any significant OA that should be causing a mechanical block like this. So that's certainly the first line of investigation. Often it's equivocal and there will be some osteoarthritis. So if we're feeling like the diagnosis is more likely to be frozen shoulder, then MRIs can be helpful there to demonstrate the characteristic inflammatory pattern of adhesive capsulitis can be really helpful. So my soft preference in these cases is to get that MRI if we're at all unsure. Because these patients do really well with an image-guided hydrodilatation with a cortisone injection. These really help with the pain and often help a little bit with restoring some range of motion. And that can make a great deal of difference in terms of the function. And we can repeat that a few times. So actually identifying that early and giving patients the option to have early pain relief and potentially progress some of their range of motion, arrest some of their range of motion loss can be really helpful if we can find that diagnosis of frozen shoulder early. So we're on to shoulder dislocations, and I've included this slide at the top here. This is an Australian cricketer. Again, this was in a Sheffield Shield domestic Australian cricket match. Joe Richardson went to high-five a teammate after taking a wicket and dislocated his shoulder. He actually came off, had the shoulder relocated and returned to the field and took about 3 or 4 more wickets for that match. So that was an unusual one. But these anterior dislocations are very common. And I think the one fact from this slide that's worth remembering is that in young people, there's an extremely high recurrence rate. So for those that play contact sports, the recurrence rate's about 90%. And even in those that don't play contact sports, it's still very high at around 70%. Every time a redislocation occurs as well, there can be significant trauma to the bone and soft tissues, which might have an impact in terms of the longer-term shoulder health of that person. And so for these first-time dislocators, they really need a good discussion about what's best management for them in particular. And for these ones, I do think it's best practice to get an MRI of the shoulder done almost routinely. And we'll be assessing for many things there: bony loss at the glenoid and at the humeral head, as well as the extent of the damage to the various stabilizing soft tissue structures in the anterior shoulder joint. And the decision as to whether we recommend they get a stabilization or not involves making an assessment of a few things, including their generalized ligamentous laxity, and if there's a degree of multi-direction and instability that was perhaps present before, as well as their sporting ambitions. So if they're planning on returning to sport, particularly if they're planning to return to contact sport, or if they're wanting to return to somewhat dangerous activities such as sea swimming, where a dislocation would put them in danger, then certainly that has a big impact on the decision making. I think a contact sport athlete that has a first-time dislocation, that is quite keen on having shoulder surgery and understands that they're going to have a high recurrence rate and they want to pursue that path, then a shoulder surgeon is a good person for them to proceed to with an MRI. But for those that are less certain on what they want to do and they want to have a bit more of a nuanced discussion about the particular risks for them and the decision making for them as individuals, and then I think these ones are good patients to refer to sports physicians. We can take the time in long consults to go through all these risk factors, go through their imaging, and help them arrive at a decision. I've just put a few slides in here about the rotator cuff because I think decisions about which ones need repair and which ones need conservative management, plus or minus adjuncts such as injections, can be quite tricky to navigate at times. And if we zoom out a little bit, I think the important point on this slide here is that many tears will do just as well in the first year or two without surgery versus having surgery. But there's certainly a subsection of those that will do much better in the longer term if they were repaired to begin with, because all tears enlarge over time. And when we're trying to weigh up which ones should consider surgery, again, we're considering the patient factors, patient's age, the size of the tear, their lifestyle demands in order to influence which ones go to surgery and which ones don't. If some tears are left for too long, they can go past the point of no return, the function never returns, and the tears extend and fatty infiltration occurs, and they become irreparable. So, it's important to be mindful of the fact that not everyone can just go to physio and conservative management for rotator cuff tears. The acute on chronic presentation is the one we really need to identify in terms of cuff tears. So the story might usually be, my shoulder's been a little bit dodgy for a while, but then I lifted something and now I can't use it at all. So a sudden functional decline like that superimposed on a pre-existing degenerative tear is sort of a red flag for us. That patient will have gone from managing to not managing, and that acute extension of the tear, changes the urgency for us. And these are the ones that we may actually need to consider surgery, particularly if the patient is young, has high functional demands, or the tear is large. Early intervention here within a few months of that acute event can significantly improve the tendon healing and the functional outcomes later compared to delayed surgery. So, that window of making that decision matters. I think the practical implication here is if someone presents with a sudden deterioration in shoulder function on a background of chronic shoulder pain, then I'd recommend referring that promptly. Usually we'd arrange an urgent MRI to assess that. Ultrasounds are also very sensitive for cuff tears. That type of story is not the patient I would send to physio for a trial of rehab first. So prompt diagnosis with that type of story can genuinely progression to pseudo paralysis. And just talking about pseudo paralysis, which is probably the other point I wanted to make, that's another red flag that should trigger an urgent referral every time as well. So pseudo paralysis is when the patient can't actively lift the arm, but we can passively move it. So that suggests there's no bony block there, and the lack of movement is definitely coming from a massive acute cuff tear. Again, these are definitely not the ones that we want to try and send to physio for rehab in the acute setting. We need to image these nice and urgently. And if we do find a massive acute cuff tear, these are the ones that should go into surgery. So there's obviously a nuance to all of our decision making here. With these tears, we're considering the acuteness of the injury, the patient demands, so what they need to do, how independent they are, what their exercise goals are, the age of the patient and the tendon quality to a certain degree, and other factors. But I wanted to give you some rules of thumb in terms of the tear sizes around our decision making as well. So small tears under 1 centimeter, these are the ones that we all see all the time. Lots of them are asymptomatic. And the good news is tears of that size have a low risk of rapid enlargement. So they're often very reasonable to ones to send to the physio and activity modification, trial a period of conservative management. The medium-sized tears, so 1 to 3 centimeters, these are sort of the borderline cases and where it can get quite tricky. The management there depends heavily on the patients, so a 45-year-old tradie with a 2-centimeter tear and ongoing functional limitation probably might need to consider repair, whereas an 80-year-old with low physical demands might do perfectly well with conservative management if they have a tear like that, and plus or minus some injectable therapies. So if there's ever any doubt as to which way to go with these, I think we're well placed as sports physicians to help navigate these decisions. There'll be a lot of patients that have a strong preference for not going down the surgical route if they can particularly avoid it. And I think we can help them with that decision making, help optimize their rehab. And, if things are stalling, then consider injectable therapies at an appropriate time for the appropriate person as well. Just a couple of quick slides on some of the high value shoulder injections. I did mention this earlier, but the hydrodilatation with a corticosteroid injection for a frozen shoulder is very effective in the acute setting of the frozen shoulder. So hydrodilatation is where we inject a large volume of saline under ultrasound guidance into the glenohumeral joint with deliberate force. And we're deliberately trying to distend that glenohumeral joint capsule. And the patients almost always get really good quality pain relief from these injections. And they'll very often get some improvement in their range of motion as well. So for the person that's struggling to put on their coat in the mornings or struggling to get things from the backseat of the car, even a 10% increase in their external rotation is going to make a big difference for them. So identifying that frozen shoulder early and getting it off for a hydrodilatation and a corticosteroid injection, their patient's very grateful for that, and it can really make a big difference. Just quickly as well, I wanted to touch on cortisone injections since it's the subacromial bursa, which is obviously a very common one that we send for regularly. I tend to think about bursitis as a secondary condition. It might be secondary to a symptomatic cuff tear or other pathology, which is causing impingement of that shoulder into the subacromial bursa. Certainly injecting the bursa in order to facilitate appropriate rehab is reasonable if we think that's where their pain is coming from and they've got clear impingement signs on examination. And we know what we're attempting to address with a rehab plan. But often we can send off for ultrasounds and the report will very commonly say that there's bursitis. I think we just need to clinically correlate as much as we can as to where we think the pain is being driven from and what the rehab plan should be around that. And if we think indeed that their pain is coming from the bursa, then it's reasonable to arrange a injection there. And again, I think us as sports physicians can help with those tricky shoulder pain cases where we're not entirely sure where the pain is coming from. There might be multiple pain sources, and we can help them get less injections, hopefully, rather than more, if we work through that process and get to the bottom of where their pain is coming from quickly. Acute AC joint injuries. So this is one where the X-ray grading really drives our management decision. So often we'll see these in contact sport players. So patient gets an immediate superior shoulder pain from a rugby tackle, for example, and when they localize it to sort of the top of their shoulder around that AC joint. The first thing we do is order an X-ray, and we use the Rockwood classification to grade acute AC joint injuries. So grade 1 and 2 is where there's minimal or there's no displacement on the X-ray through the clavicle and the AC joint. It's either in a normal position or that clavicle is slightly elevated. And we conservatively manage those ones with a sling for comfort and analgesia and early physio. Most of those do very well and relatively simple. Grade 3 is the controversial one, where that clavicle is elevated by up to 100% of its width compared to the other side. And the traditional teaching in times past has been to get surgery for those. But I think most people these days are favoring conservative management for those grade 3 injuries, at least a trial of it, as the surgery doesn't consistently outperform conservative care for those through trials. And obviously there's a complication rate with any surgery, and particularly that one. The other condition I'll quickly touch on this slide is osteolysis of the distal clavicle. So that's when the end of the distal clavicle effectively resorbs through repetitive trauma over time. So we see that in highly active middle-aged people, gym goers, bodybuilders, that sort of thing. Corticosteroid injections into that AC joint can be really effective, and talking them through appropriate activity modification is definitely the first line of treatment as well. I'll skip over this slide and I'll make sure we include it, but this is just some quick thoughts on where to image, which body parts to image. And in the interest of time, this is just a quick slide to briefly mention that we see lots of work cover cases that fall into categories of shoulder and hand injuries, such as rotator cuff tears, that can be difficult to manage. Who needs surgery, who doesn't? How to optimize the rehab, when are injectable therapies appropriate? We're obviously very happy to see those, and we treat those like elite athletes in terms of trying to help them get back to work and function as quickly as possible. So if any of you have any questions about any of that, please let us know at the end, and myself and Dr. Samra will be very happy to answer any questions. And I will hand over to Cameron now for his part of the presentation. So thank you very much.
Yeah, thank you. Especially for your sharing those valuable insights. So our last speaker is Cameron Hyde, and his presentation is on exercise physiology in the era of effective weight loss medication, in particular the GLP-1RA. So yes, thank you, Cameron.
Thanks, David and Leigh, for great presentations, and thanks again for Dr. Leigh and Lydia for organising tonight. I'm Cameron Hyde. I'm an exercise physiologist. I've been working in the space for 10 years now, and I started out working with complex musculoskeletal cases across many clinics in Sydney, and then started to work for myself to follow my passion in the metabolic health and in the longevity space. And these GLP-1s are medications are obviously the most effective weight loss medications that we're seeing. So I think it's been a really good learning curve for myself and in the clinic here to develop a procedure or protocol so that we're giving patients the best education and advice for long-term results. This is a ChatGPT AI generated image of myself, and 10 years ago when I started as an EP, if I could see myself here, somewhat promoting the use of these weight loss medications, I'd say you're crazy. But in the advancement in technology and in medicine and AI, we're ideally hoping to see people live longer and healthier lives. So today we'll talk about the drugs themselves and their effects, and the short and long term goals that we're sort of setting with these clients. And really the big part here is the preventative measures, measuring lean muscle mass and fat mass and bone mass as people are losing weight, and then reassessing to make sure that we give appropriate gold standard evidence-based advice. So why this matters, obviously we're seeing weight loss in terms of total body mass loss with the use of semaglutide and tirzepatide between 15 and 25%, which is far better than any lifestyle intervention alone. But with the evidence that we have at the moment, people are losing anywhere from 20 to 45% of that coming from lean mass and bone mass, which puts people at risk of reduced function, frailty, and then obviously the weight regain that we are seeing as well. I think the real big piece to the puzzle here is allowing our patients to have or be involved in an educated multidisciplinary team with the GP as the center function, and then with an exercise physiologist and dietitian as well, giving appropriate evidence-based advice so that we can ensure that fat loss is prioritized, lean mass is preserved, and that we're getting the best long-term outcomes here. And I think a really key part that we've sort of developed or found in the clinic is somewhat screening for any history of eating disorders or disordered eating, and screening for these things and asking questions about their relationship with food before they endeavor on a weight loss journey. Things like are they eating breakfast? What's their history as a child? And really trying to delve into what their relationship with food is like. And I think that that's been a key part that we've sort of learned through the clinic here. So our screening process within the clinic here, Progressive Sports, we have a non-negotiable. So any of our clients or patients that are taking a GLP-1 or thinking about taking a GLP-1 agonist, our non-negotiable is that they complete a DEXA scan, so a body composition scan. And the reason for that is we want to look at what their lean muscle mass is before starting the medications, because we know that there's going to be significant loss over the course of their weight loss. So later on in the presentation, we'll look at a few examples of people that have come into the clinic that have been taking the drug but have actually been sarcopenic before actually taking the drug. We're also looking at some strength metrics and then screening for their protein intake and, once again, their relationship with food. And my job here as the exercise physiologist is to provide the appropriate exercise advised basic nutritional guidelines and parameters. By no means am I a dietitian, but a lot of people's diets are very poor, and it's quite easy to make successful changes just through conversation and education. So I definitely will talk about that as well. So this is simply just looking at the relationship of lean body mass or lean muscle mass loss with diet in behavioral interventions alone versus the incretin GLP-1 agonist versus bariatric surgery. Obviously, we're going to see a lean mass loss in any rapid weight loss. However, it is being shown that there is significantly more aggressive weight loss with the use of these medications, and therefore higher amounts of lean muscle mass loss as well. So we're trying to figure out ways in which we can mitigate that as much as possible through education on nutrition, appropriate exercise intervention, frequency, duration, and intensity. And then how do we apply that in a sustainable, long-term, realistic manner? So we'll run through the step one research paper, which was done in 2021, looking at the effect of weight loss using semaglutide. It was a double-blinded, randomized, placebo-controlled trial known as step one, which had almost 2,000 participants with a BMI greater than 30, but without diabetes. They were randomly assigned a group either taking placebo or once weekly semaglutide, titrated up to 2.4 milligrams over 16 weeks. The results are pretty obvious there that changes in total body mass was pretty aggressive over the first 36 weeks and then seemed to taper off after about 12 months. The next graph here is a step 4 research paper, which was a phase 4 trial, which involved 800 participants who received the same dosage up to 2.4 milligrams, titrated up to 16 weeks. And then a third of them were switched to a placebo. And we're looking at the effect of continuation of semaglutide versus complete cessation. And it's pretty obvious here that the complete cessation of taking these drug yielded quite a large regain of weight over the next 52 weeks. So the education that we're trying to give these patients is that, the research and the data is suggesting that there is weight regain after cessation. So what's an appropriate treatment or appropriate titration down from a higher dose, and then providing appropriate behavioral management strategies, resistance training, and sufficient protein intake to help to mitigate any muscle loss. So we'll talk about tirzepatide now, so Mounjaro. So this is a study from 2022, which was a phase 3 double-blinded randomized placebo-controlled trial with 2,500 participants. I think it's important as well to note that in these trials, the advice that each person was given was pretty limited in my understanding, is that they were told to exercise 150 minutes a week of moderate intensity exercise. And when they described moderate intensity exercise, they described it as brisk walking. And brisk walking, in my expertise, is definitely not moderate or even close to that in terms of the intensity. And there was no suggestion of completion of resistance training as well. They were given behavioural support or regular counselling sessions once every 4 weeks, and they were told to be in a 500 caloric deficit. And their caloric maintenance was estimated using an equation. And the literature and the research can suggest that some of these equations can be upwards of 30% either under or over, especially in obese patients. So there are some interesting procedures with these studies. And my impression is that there probably could have been significantly improved results or outcomes from these studies should they've been taken through and given appropriate advice in terms of protein intake, the timing of that protein, and then especially the resistance training component. A general advice of 150 minutes a week can mean anything. Like, people that I'm seeing in the clinic will, most people go for walks and they walk their dog, and it's very low intensity, especially if they have, a really old dog who just sort of plods along, but they'll count that in terms of their total minutes in a week of exercise. So the results of this study here was quite significantly higher or improved results versus the semaglutide. Over 72 weeks titrated up onto the highest dose of 15 milligrams, people were seeing up to 22% of their body weight, of their initial start weight. Not a big difference between 10 and 15 milligrams, but then a significant difference between 5 milligrams and 10 milligrams. I think that obviously when we're comparing this to a placebo, still quite significantly improved results, and the people that were taking the placebo drug were also given the same advice. I think that in the clinic and in my experience here is that I'm seeing a lot of clients that are taking these drugs, and we're having the conversations around expectations, and I'll show them this data in our initial consultation, and I set an expectation that if they're losing weight this quickly, in terms of what the research has suggested, I'm actually not quite happy with that. I'd actually prefer it to be a lot slower, because we know that with with Mounjaro, that they are also losing muscle mass as well, and I'll get to the slide that summarizes that shortly. Once again, this is the follow-up trial, the SURMOUNT-4 trial with tirzepatide, looking at complete cessation of the medication. However, in this trial, they had dietetics involvement, and the dietetics involvement advice was that their caloric intake was once again estimated using an online equation, but they were told that they were to have 50% of their caloric intake was to come from carbohydrates, 20% from protein, and 30% from fats. So if we do some calculations in my head right now, if they're having 2,000 calories and 1,000 calories of that's coming from carbohydrates, that's still 250 grams of carbohydrates, and it's 50 grams of protein. And if we're looking at optimal protein intake for mitigating muscle loss, we're looking at upwards of 1.6 grams per kilogram of their goal body weight. So it's still significantly less when the average weight of these people in this study was over 100 kilos. So they're somewhat a third less of their protein intake that they should be having in terms of trying to mitigate muscle loss, because the presence of higher amounts of protein intake, what that will allow will be that bioavailability to mitigate muscle loss and allow for a greater adaptation anabolically with a less amount of exercise stimulus. So once again, my impression or interpretation of this is that that advice could have been significantly better in terms of getting better outcomes. Because when we look at the effects on body composition from these studies, the step 1 study using semaglutide saw about approximately 15% of their body mass loss from their total start weight. However, 45% of that was from lean muscle mass. So if they're losing 15 kilos, it's 7 kilos of muscle mass, which is not great. I think that some of the people who have been going through and taking these drugs and losing a lot of weight really quickly, often when they're losing that much amount of muscle mass, they can often end up worse in terms of fatigue, poor exercise, consistency, a higher risk of cardiometabolic disease, or even some people in the clinic that we've been seeing have had an increased body fat percentage even after losing 10 kilos. So it's important to note as well that people who initially had or have had diabetes taking these drugs saw significantly less total weight loss. And then when we compare that to Mounjaro or tirzepatide, people were seeing such a greater loss in their total body weight from baseline, up to 22% over 68 weeks, and only a 25.7% loss in muscle mass. I'm unclear or unsure on the physiological reason that is, if they were given the same advice. It's really interesting when people are coming in taking Ozempic, or they're coming in and taking Wegovy versus Mounjaro. I definitely am seeing far better improvements in body composition over the course of their treatment than Ozempic or semaglutide. So I think this is a really important slide, and it's led us in this clinic to create these non-negotiables of having their DEXA and their lean muscle mass measurements and visceral adipose tissue measurements at the start of their treatment, and then being able to provide evidence-based education and decision-making around should they continue the medication, should the dose go up, what's the conversation between the GPs and myself and the dietitian involved. Do we need to be more aggressive with our resistance training protocols? Do we need to increase the frequency? Or do we need to increase protein intake? And we're tracking these things sort of every 12 weeks. And it allows us to measure, assess, reassess, and make sure that the weight that they're losing is coming from the tissue that we want them to lose. Obviously, there are some adverse reactions that have been demonstrated through these papers. Nausea, constipation, diarrhea being the most common. What I'm normally seeing from in the clinic, seeing some of these patients every week and seeing them increase their dosages, is that generally at the start of their first dose, nausea, bit of constipation or GI upset. And then when they increase their dose as well, sometimes that first dose, they have these symptoms as well. And then we're just sort of tracking and seeing how they're tolerating those changes to their dosage. And obviously this is a discussion or a conversation that the client would have with the GP, and I might be giving some feedback to the patient to go back to the GP and to discuss the side effects and how it's affecting their life. But I think being on top of those things and understanding those things is really important. So this is a really big question that I get within the clinic when I'm often bringing up the idea of talking to the GP about taking one of these medications. Is, I don't want to do the medication because we're just going to regain it all after. And it's a very common theme that I see with patients. And are they right? Yes, there is evidence to suggest that there is weight regain, as we've seen in the previous slides. However, not everyone regains a lot of their weight, and there are quartiles of evidence to suggest that there are people who regain 25% of their body weight, and then up to some people are regaining 75%. I think that the intervention here that we're trying to, I guess, promote across the clinics, and as part of this, I guess, education night as well, is what's the appropriate management? What's the appropriate education? How do we implement something into that patient's life that's sustainable and realistic to minimize and mitigate the worst outcomes here? And I think by having a really good team around us here and being able to complete these imaging of the DEXA scans and using those as our guidelines to either be more aggressive with parts of our advice or parts of our treatment versus in some cases even suggesting to stop taking the medication with a letter to the GP. So I think this is one of the two key slides. If you want to take a photo, or I'll send it through a PDF of the presentation later anyway. But it's essentially trying to summarize the research in how to mitigate muscle loss during weight loss. Protein intake and resistance training are by far the biggest indicators here. There is some newer research into drugs, myostatin and activin type 2 receptor inhibitors, trying to stimulate muscle growth and then also losing body weight. Nothing approved through the PBS yet, or the FDA, but there is some new exciting sort of drugs coming out as well. I think that my biggest conversation in the clinic is looking at their nutrition from an initial consultation point, sort of setting a bit of a standard guideline in terms of how much protein would be optimal for them to minimize muscle loss, and then even see positive adaptations to their muscle during a weight loss phase. And then obviously getting an involvement of a dietitian should there be any really complex GI issues or history of eating disorder or disordered eating. Another important part here, the education on what to expect in terms of feelings, emotions, and senses after the cessation of taking these drugs is that there are some physiological changes that do happen. There is a reduction in resting metabolic rate in terms of how much energy they take to or need to stay alive if they were at complete rest. And there's also an increased or a bounce back of ghrelin sensitivity. So people are feeling more hungry after stopping the medication, and then their maintenance calories of their resting metabolic rate is also reduced. So it's really challenging to navigate this space when people are feeling more hungry, and for them to put on weight, their maintenance calories is actually less. So during this part, we really focus on increasing some intensity of some aerobic exercise and really honing in on resistance training and then timing of fuel. And obviously working with some good dietitians can really help this as well. So I think let's go through some examples and the importance of screening. So this was a lady that came into the clinic, 51 years old, referred to me for weight loss and significant fatigue. She was menopausal 2 years prior, wanted to lose some weight that she felt, and she felt that she was overweight and weak. She was already taking Mounjaro for 4 weeks, prescribed from her GP. We completed a DEXA as part of our non-negotiables within the clinic, which highlighted very high visceral adipose tissue. So she was 59.9 kilos when I did this screening and did this scan. And her ASM over height squared, so that's a metric used in the diagnostics of sarcopenia. So for women, less than 5.5 is part of the criteria for diagnostics. So she was 5.1, so very low muscle mass and very high visceral fat. And my immediate action was to contact the GP, ask for her to be taken off the medication because she was already sarcopenic. So the advice to her then was to go through a really thorough strength training program to try to increase her muscle mass, some low intensity aerobic exercise because of her high levels of fatigue. But I think it's a really important reason or why screening is really important. I know that I'm sure that you guys have seen a lot of patients who have come in and they just want to lose a few kilos and they want to take these drugs to help because it's the big popular fad and very, very popular at the moment. But for example, this lady, it was really important that we got on top of this straight away. Because if she continued on that trend and she lost more weight, we know that there's going to be a significant reduction in muscle mass loss without any appropriate advice. So we got on top of that straight away. Right, this is a really interesting one. So this is a case study of a 68-year-old female. This initial DEXA scan was completed in August 2025, where she had 43.8 kilograms of muscle, which is actually really good. Her ASM over height is metric is 7.6. So once again, really actually was quite impressed and happy with that. The scan prior to that, she had 47.8 kilos of muscle, and she'd lost 9 kilos in 6 months. And of that, it was about 4 kilos of muscle. So, sorry, she lost 7 kilos total body weight, and 4 kilos of that was muscle. So 55% of that body weight that she had lost had come from muscle. I was only completing her scans in this case. I wasn't her exercise physiologist. I was just completing her scans, giving it to her personal trainer / coach that she'd got online. This lady was from the South Coast. Very interestingly, she was told to do 2 full day fasts a week, and was only doing 1 to 2 sessions of resistance training per week, and often missed days and weeks because she was so happy that she was losing weight. This is the most recent scan that we had for her, completed in February 2026, where she lost another 1.9 kilos, where she was once again feeling quite happy that the number on the scale was coming down. However, of that 1.9 kilos, she'd lost 3 kilos of muscle, and she'd gained 1.1 kilos of fat. So a really important part about our non-negotiable here is doing these scans to make sure that the advice and exercise and nutrition that these patients are doing are actually yielding positive results. Because even though she's lost 10 kilos from her start weight, she's in a much worse position. She's feeling more tired. Her exercise capacity is less, and her muscle mass is considerably reduced from her initial start weight. So with her 10 kilos lost, 7 kilos of that was coming from muscle. And she was feeling it in her day-to-day as well. So I think that my advice for this lady was I wanted to take charge of what she was doing. I wanted to provide her with sufficient education, get her to see a really good dietitian, write her exercise plan and her exercise program with appropriate intensity, duration, and frequency so that we can actually see a positive bounce back from this. This is another example of how she lost weight, but her body fat percentage went up. So she went from 45% body fat to 47.5%. And as a 68-year-old female, that's going to be incredibly difficult to regain that muscle, probably looking at, if she would ever, but at least 12 to 18 months minimum with a diligent, consistent program for that entire duration. So a lot of work to undo the damage. This is just sort of highlighting those metrics and the track, of course, over the 4 scans that we'd completed. This was a resting metabolic rate of the same lady. So a loss in muscle mass resulting in a reduction in resting metabolic rate. Another reason why when people are stopping these medications that their resting metabolic rate is reduced as well, with a reduction in lean muscle mass, which is a thermoenergetic tissue requiring energy to stay alive. We're seeing reductions in the energy required as a maintenance level. So we're doing these tests as well as an option, not as a non-negotiable. A lot of, I think particularly menopausal women or postmenopausal women will come in and will do a resting metabolic rate test, and they'll say they've put on 5 kilos in the last couple of years and their metabolism has slowed down, or their metabolism is slow, and we'll do a resting metabolic rate test and they'll be completely normal. It's actually more unlikely that their metabolism is actually slow, unless there's some pre-existing thyroid or parathyroid issues going on. All right, let's talk about the intervention. So I am really big on exercise snacks, and the irony of this is that for people losing weight, when I refer to exercise as a snack, they always smile and laugh. So an exercise snack is a small bout of high intensity exercise. It could be something as simple that I use in the clinic a lot as a rapid or fast step up. But the goal of an exercise snack is to elicit a high cardiovascular and respiratory output with low risk of mechanical loading. So something as simple as a 6-inch step, when the advice is to step up and down on the step as quickly as you can without running. Even people who present with hip OA, acute knee pain or ankle pain, lower limb injuries, they can still complete this because the step is not high, but the speed and the effort is high. So it's the intensity that matters the most. And the vigorous effort is very feasible. It's evidence-based, and people can complete it at home. They can complete it at work. People who are office workers or working from home, I'll often get them to purchase one of these steps. It's $20 from Kmart, and I'll get them to put it next to their desk. And I'll associate every time they leave their chair before returning, and I want them to complete 1 minute of these fast step-ups and trying to accumulate 6 to 10 efforts in a day. And the evidence is overwhelming that the metabolic and cardiorespiratory effects are significantly higher doing a high, vigorous, short burst of exercise than going for a 30-minute low-intensity walk. So less time investment with a higher return on investment. So these have been really, really successful in implementing because they're so feasible, very easy to do. It's just about educating the clients on what the expected results are and then associating the vigorous effort with something that they do often. So putting the kettle on, going to the bathroom, getting up from their chair. Literally, people are doing that many, many times in a day. And the reported feedback that I'm getting is it's actually quite easy to get 5 in a day when they associate it with something that they do often. So if we think about the ACSM exercise guidelines, which suggest 150 minutes a week of moderate intensity exercise or 75 minutes of vigorous exercise, and to complete at least 2 resistance training sessions per week. This was a study that came out this year, which looked at 73,000 participants from the UK Biobank, averaging 61 years old. And they were looking at the probability or hazard ratio with associated cardiovascular or metabolic disease. And they were looking at their wearables, so an Apple Watch, a Garmin, a Fitbit, and how often they were in or how often their exercise was either vigorous, being a heart rate greater than 85% of their max heart rate. And what they've found and reported is that 1 minute of vigorous exercise is actually more like 4 to 9 minutes of moderate intensity exercise. And as I was speaking about before, was that brisk walking is not moderate intensity, it is light intensity. And going for a walk with your dog is also light intensity. And they also found that the 1 minute of vigorous exercise was equivalent to 53 to 150 minutes of light activity. So a 2.5 hour walk versus 1 minute of very high intense short burst of exercise was equivalent. So I was pretty astonished, to be honest, when I read through this, and I've been telling people to do these sort of exercise snacks and high intensity bursts for a long time, and to have some evidence to support my crazy approach has been quite nice. And these are things that, as GPs, you can actually prescribe straight away. It's very easy for people to have access to a step. It's easy for people to do rapid chair stands. Skipping is another really good one. Running on the spot is another really good one. And it doesn't really matter what modality of aerobic exercise it is, as long as the intensity is high. And the intensity on an RPE scale, anywhere from 6 to 9 out of 10, and trying to accumulate anywhere from 6 to 10 minutes per day is far above what is recommended and far above what is in the research. But it is a dose-responsive relationship, especially for these patients who are A, either time poor, or B, do not like exercise, or C, have a low exercise capacity. So being able to exercise for a prolonged period of time to see significant results, these are very feasible and realistic implementations that you can even start people with. So that's a really important point. I'll quickly wrap things up, but the EP consultation process for anyone who presents taking a GLP-1 medication is initially screening for any disordered eating history, either optional resting metabolic rate assessment to identify their maintenance caloric intake. A non-negotiable is the DEXA scan, looking at their skeletal muscle index, their visceral adipose tissue, body fat percentage, and lean muscle, and then completing a grip strength and a lower limb or upper limb strength assessment. And generally the advice is to complete a little bit often. So frequency by far trumps duration with patients who are completing resistance training who have a low history of exercise capacity or don't really know where to start. Something as simple as 3 body weight exercises, 3 sets of 10, that is just a push-up, a squat, and a lunge, or a squat, a calf raise, a glute bridge. But it's the frequency of that effort and the frequency of that stimulus that will yield greater results than the duration and the intensity of the resistance training. We'll always talk about protein intake as their 1.6 grams of protein per kilogram of their body weight as a goal. And we will test their DEXA and retest at 12 weeks and provide a thorough report. A positive note is an example of implementing these procedures within the clinic. This gentleman was on Mounjaro for 2.5 milligrams and then progressed to 5 milligrams. I'm not sure if you can see the number. Can you see the numbers there? Well, I'll go through them. So he lost 4.9 kilos. His visceral fat reduced 400 grams. His muscle mass increased. I don't have the actual DEXA that has the image that has the total muscle mass increase, but he increased his muscle mass by 6 kilos and lost 11 kilos of fat. So a prime example of the weight that he was losing was slower, but his composition was incredibly improved. And this man was super diligent to his exercise and nutrition advice. The last summary point basically summarizes everything that I've just spoken about in one slide. Talk about the intensity matters the most with the exercise snacks, something that's short, sharp, sweet, and fast, and mechanically low load. Always screening for lean muscle mass for appropriate GLP-1 users, and determining a safety net point for both men and women. Mitigating muscle loss with protein intake, guidelines, dietetics involvement, with protein making you feel satiated, so people are feeling fuller for longer, as well as the effects of the medications as well. Increasing the incidental movement, aiming for up to or upwards of 8,000 steps per day is a really good target. And to get people to do this, a walking pad is a really good one if they have a stand-up desk at home. It's about $199 off Amazon, and they can walk at 2 kilometers an hour while they're taking meetings or phone calls. And I've seen some of my clients go from 2,000 steps to 12,000 steps in a day without leaving the house. So a really good tool or trick that you might be able to suggest as well. Cool. Thank you.
Thank you, Cameron. Thank you for your presentation, especially for making us more aware of possible side effects and complications when we're prescribing a GLP-1 for our patients. So the presentation ran a little bit over time, so we don't have that much time left, but we'll try and go through as many questions as possible. So first question is for David, and the question is, are ankle straps and knee straps good as a protection for players when they're playing, for example, netball?
Thanks very much, Edmund. Look, I'll leave this open to Leigh as well. The data would suggest that for ankle sprains, where there's a significant loss of proprioceptive function when a ligament is torn around the ankle, the risk of recurrent ankle injury drops significantly to the point that a patient would be 5 to 6 months down the line from their injury from the moment they strap or brace their ankle. The quality of braces varies, so I'd always leave it with an experienced physiotherapist to suggest which and any fitting of braces. But I think there's good evidence for ankle inversion sprains and prevention of recurrent injuries. And I would tend to suggest that most active adults and children who have an inversion sprain should consider regular bracing or strapping for an entire 12 months following a high-grade injury. Certainly if they're missing time from their sport on their return. Obviously, there's practical considerations to that. The knee is less likely to have good evidence, and it probably more relates to comfort, security, proprioception than but for patellofemoral subluxation, there's more evidence around customized taping. Jenny McConnell's an Australian physiotherapist who's probably the most published in the area, and patellofemoral taping for pain can be very effective, but for subluxation and dislocation and instability, the results will vary widely. So good for the ankle, not as clear-cut for the knee, and depends on the indication for the knee, I would say.
Yeah, that's definitely my practice as well, Dave. You know, it's a rigid ankle brace is what we're talking about there, and particularly one that's well fitted.
I think without having any commercial conflict of interest, I would generally recommend any company that has a store or the ability for people to try on their brace before they buy it. And Bauerfiend is one of those stores in Sydney. They've got a store in Gladesville, one in the CBD. There's lots of bracing companies out there, but I think being able to actually feel the security and the fit is important.
It's good, thank you. The next question is on PRP. So if I'm a GP and I've got a centrifuge, can I start doing PRP injections on patients? And also, how effective are they? What is the latest on PRP?
This one?
I'll have a few that.
Okay, so PRP injections are controversial in terms of their efficacy. They've been the difficulty, and this stems back to research I've done on PRP over a long period of time, both qualitative and quantitative research. One of the most challenging things about PRP is that it's an autologous blood product, and it varies therefore between individuals. Protocols vary in terms of the centrifuge speed, the use of commercial or non-commercial kits. We have over time developed broad categories for PRP as to whether it has white cells or it doesn't have white cells, and how concentrated the platelets are. But overall, broadly, when we look at systematic reviews of all of the trials of PRP used for joint injections, osteoarthritis, versus soft tissue injections, usually tendinopathies or ligament injuries, there seems to be a pattern that leukocyte-rich PRP, higher white cell concentrate, is more effective for tendinopathies and tendon injuries, and ligament injuries. So I did research on syndesmosis injuries, and we found it was a cohort study, but we've found that rugby players returned to sport about 5 weeks earlier if they had had a single PRP injection within 2 weeks of having a syndesmosis injury of the ankle. The other group is the leukocyte poor, and they seem to be more effective for arthritis, osteoarthritis, pain. But the evidence, the higher the quality of the evidence when you look at all of these studies, the lower the sources of bias, the lower the effect size. And that's the challenge, is that every time a study comes out that says, well, it didn't work for medial compartment osteoarthritis. There was a study published in Australia with over 100 patients and double-blind crossover placebo control, and they found that compared to normal saline injections, patients who had a course of 3 PRP injections were no better clinically or radiographically or radiologically for medial knee osteoarthritis. So I'm less of the view that it's helpful for osteoarthritis. I tend to lean toward the use of hyaluronic acid based on that well-conducted study. I still think it's quite helpful for ligamentous injuries and soft tissue injuries like tendinopathies, like the Achilles, small rotator cuff tears. To your question of whether, as a GP, you can buy a centrifuge and perform it, there's no regulatory restriction to doing that. Obviously, the training that occurs, so on the sports medicine training scheme, occurs during the fellowship years, and it varies based on the training positions you've had. So in some countries or in some states, registrars are not taught how to do PRP injections. In Sydney, you generally are. And then, what centrifuge, what speed, what time, how do you produce your PRP, and do you inject under ultrasound or not? Those are all questions for each doctor to answer. But I think to become competent in that, it either requires experiential learning or performance of some sort of course. There's usually not very much out there. But yes, it's the sort of thing that, if you're looking for experience, you would usually spend some time in a sports medicine clinic.
Thank you. I would like to thank all our speakers tonight for the excellent presentation.